Hi there, I'm Ryan. This video is assessment number 3 for Foundations of Advanced Paramedicine. I'm completing the respiratory assessment portion. Before the video begins, there's a few things I need to say. I completed this video at an ambulance station within Victoria. The day of recording, there were no staff on site at that particular time. The day shift were out, the afternoon shift weren't due to start for a couple of hours, but you'll hear and see a monitor within my assessment portion of the video, and that monitor was marked for their ambulance. So we need to make sure we got the assessment done as swiftly as we could. You'll also notice within the video there's no PPE being worn. Unfortunately, because there were no staff on site, I couldn't get access to where the PPE was stored. And particularly during these COVID times and respiratory cases, a face mask or a surgical mask should be worn. But in some recording attempts, I found that wearing a face mask really impeded with the microphone's ability to pick up audio. So we've kept it off just so that we can make sure that we can hear the portions of the assessment and the questioning. During the video, I'll also pause and cut away from certain points to give important information about an assessment I've just completed, or about things going through my head like differential diagnoses. So the case, all we're told, 68-year-old male, shortness of breath, and initial set of vital signs. This may not seem like a lot, but that level of information, being patient's age, gender, we can help formulate some sort of differential diagnosis before arriving. So in this case, a 68-year-old male complaining of shortness of breath, things that should be within the differential before even arriving should be things like an acute myocardial infarct and COPD. Without any further ado, off to the video. Hi there, my name's Ryan. I'm your paramedic this morning. What's your name?
Oh, my name's Mike. Hi.
Hi Mike, why have you given us a call today?
I'm short of breath, mate.
That's no good. I'm sorry to hear that. How long have you been feeling short of breath?
Oh, just since a bit after I woke up today.
Okay, all right. Were you short of breath before you went to bed this morning?
Oh, a little.
Okay, all right. If it's all right with you, I'm just going to take some blood pressures and check your pulse and check your temperature. Are you happy with that?
Yeah.
Excellent,
Yeah, sure.
Thank you. So do you have any pain or anything like that at the moment?
No, no pain.
No pain anywhere at all?
No.
No, all right. And how long have you just been short of breath the last couple of days, or has it been multiple days?
Oh, really just a bit since yesterday.
Okay, all right, so really only the last couple of days.
Yeah.
Now, with your shortness of breath, I'm just hoping, if you're happy, can you say your full name and your address for me? Try, if you can, to say it in one breath.
Yeah. My name is Mike Galano. My address is 12 Davidson Street.
Okay, thanks for that, Mike.
Yeah.
All right, just checking your temperature. All right, so just a quick cutaway for the vital signs. Pulse is 80, blood pressure of 145 on 85, a temperature of 37.8, and SpO2 reading of 95% on room air, and a respiratory rate of 28. Please keep in mind, Mike did his best to replicate this. He's getting a bit lightheaded, so please use your imagination. One of the last assessments I got Mike to do was to try and say his name and address in one breath. I found this to be an easily replicable assessment to determine if a patient is speaking sentences, short phrases, single words. Easily repeatable. It can also help us determine if treatment is effective or not. So differential time. We do have some information, not a lot, which does mean that our differential diagnosis list is quite large at the moment. Things that should be included on it, things like chronic heart failure, acute myocardial infarct, chest infections, sepsis, asthma, emphysema, anxiety, arrhythmia. Please keep in mind this list is not exhausted, but we can start eliminating or adding to the list with further questioning and examination.
Based upon how you're currently presenting, I want to do a thorough respiratory assessment, and I'd also like to do an ECG of you. If you're happy to take your shirt off, that'll allow me to continue the rest of the assessment. Are you all right with that?
Yeah, that's fine.
Thank you very much for that. So when you're ready, you just take your shirt off. Now, have you been having a cough as well?
Yeah, I've been coughing into that.
Oh yeah, has it just been that colour? Like is that sort of normal whitey colour, not green or yellow or anything like that?
Just like that.
No, okay, and you've been using this as well, have you? Okay, that's all right.
It's not helping.
All right, so to way this respiratory assessment starts, I'm just starting here from at this point. I'm going to have to come in and get hands-on at a certain point, but I'll let you know about that before I do it. Are you all right with that?
Yeah, mate.
Excellent, that's not a problem. So what I'm doing, I'm just making sure I'm looking around. I can see that you've got your sputum bowl and your Ventolin here. It leads me to think that you've been using this. I'm also looking for a sort of posturing in that. You can sort of see you're tilted forward a little bit, trying to tripod yourself up, makes your breathing a bit easier. So I'm also looking at your feet. I'm just going to be feeling down here, making sure we've got no peripheral edema, which is good. You don't have any.
Okay, so we've just completed the part of the assessment from the edge of the bed. Mike's stay has been a few days. He's had no pain at any point. AMI is looking less likely, but not impossible. We can see he's got a sputum bowl. There's clear clone sputum in it. He's showing no signs of peripheral edema at this point, so it's less likely to be chronic heart failure. We can see he's got some sort of partial positioning. We've got the clear sputum, and the Ventolin does lead us a little bit closer towards some sort of obstructive disorder like asthma or emphysema.
So if you can, I'd just like you to stick your hands out for me, straight out. Now splay your fingers for me. Now I can see that your fingers are twitching just a little bit, which means that you've been using this, which is good. Now what I'd like to see, if you can, just curl your arms back, your wrists back like that for me. What I'm looking for is anything we call asterixics, which you don't have, which is all right. Excellent. You can relax those arms down for me. I'm going to be feeling your arms, making sure they're the same temperature all the way down. That's good. All right, that's what we like to see. If you can, I'm looking for clubbing. So what this means, I just need you to put your 2 index fingers to me, just like that. Perfect. I can see the little diamond shape. Perfect. Thank you very much. You can relax it.
Pausing here. So Mike clearly has been using his Ventolin. We can see the finger twitches being, there's being a side effect of the beta-2 agonist use being the Ventolin. Mike doesn't show signs of asterixics, which would be an acute sign of carbon dioxide buildup causing metabolic encephalopathy. Touching down Mike's arms is assessing peripheral perfusion issues. If one side was cooler than the other, it would mean poor perfusion to that particular side. And the finger clubbing assessment is looking for lung diseases such as lung cancer or bronchiectasis.
So now I need to look and see if you've got any extra jugular venous pressure. So if you can, just look towards your left for me. That's okay, it's not raised or anything like that. Perfect. You can come looking back at me again. You stick your tongue out for me. Excellent. Raise it to the roof of your mouth. Raise your tongue to the roof of your mouth now. No, there's no blue colouring indicating cyanosis, which is good. We're looking at your eyes just for a second, and if you can, perfect, can you just pull one finger down, pull your eyelid down for me? Excellent. That's the colouring we like to see, which is good.
Okay, so what we've done here, we've turned Mike's head to the left. We were looking for raised jugular venous pressure. So looking along here to see if we can see the jugular vein while at rest. If we could see it, this would be indicative of right atrium pressure changes from something like cardiac congestion or chronic lung diseases. When we were looking at Mike's tongue, this can assist in determining central cyanosis, something like a chronic smoker. When we look at Mike's face and eyes, we're looking for signs of Horner syndrome. Someone who shows signs of Horner syndrome can indicate some sort of lung cancer. So the signs of Horner syndrome, you would see one eye drooping, you'd see a small pupil size, as well as one side of the face not sweating. When we were looking at Mike's conjunctiva, so getting him to pull down his eyelid, we were looking for signs of anemia. If the conjunctiva is pale, it indicates signs of anemia. I had to speed up that portion, I'm sorry. It took a lot of time to record and placing all the dots, so I sped it up. Unfortunately, that's affected the audio. So while we're placing the ECG, we are looking for signs of chest wall scars. So scars across the sternum would indicate us towards some sort of coronary bypass surgery or valve replacement of some way. When I was getting Mike to lift his arms and looking for lateral chest wall scars, that indicates history of chest strains. So while I was placing the ECG, doing a lot of questioning of Mike, asking him a lot of questions in regards to risk factors and family history. So risk factors that popped up in this particular case, Mike said he's a current smoker, and Mike said that he doesn't visit his GP regularly. So those are little yellow flags to keep in mind that we should be thinking about things in regards to emphysema, and that he doesn't see his GP to get properly medicated for diseases he may not know that he has. I asked about his family history. Mike said that both of his parents are still alive, and they've just got diagnoses of high blood pressure. So family history-wise, not a lot to go off.
Now, while that's printing out, I'm just going to be looking for any sort of asymmetries with your lungs and your chest wall, okay? So when I tell you to, I'll be asking you to take some deep breaths in, all right? So when you're ready, just nice and deep breath in for me. Excellent. Now that doesn't change, that doesn't cause any pain for you or anything like that? No. Good. Another big one. Good. Just going to come around the back and do it on the back as well. Deep breath in again. Good, symmetrical, excellent. And one more again for us, Mike. Excellent, that's good. Now, looking at your 12 lead, there are no major indicators of ST elevation. The P wave's a little enlarged, but a good PR and a narrow QRS complex. All right.
So this portion, while the ECG was printing, I was conducting a chest wall assessment of Mike. So a hand on either side of his chest, just asking him to take a deep breath in and out. We could determine if there's any chest wall abnormalities. So if one side of the chest doesn't rise or fall as effectively as the opposite side, it can help us determine if there are particular sort of lung issues or rib issues. In this particular case, it was fine for Mike, and when he took a deep breath in and out with some resistance, it didn't cause him any discomfort either. So when the ECG printed out as well, doing a quick analysis, it was sinus, it was regular, QRS was narrow, and there was no ST segment changes, which really puts an acute myocardial incident pretty much out of contention in regards to differential diagnosis.
Next thing I'm going to do is I'm going to perform some percussion on your chest. So you'll just feel a finger on your chest. I'm just going to be tapping on it multiple times, okay?
Yeah. Okay?
You don't need to worry about anything. I'm just going to take these ones off just to get this out of the way. going to perform that again on your back.
Mm-hmm.
So what I'm listening for is if I hear anything particularly dull or anything hyper resonant, that would tell me a different story. But your lungs sound fine.
So the percussion test, what we're looking for here is different types of sounds or different pitches that you hear when we're tapping on the chest wall. So what we're listening for are particularly dull sounds. So the dullness is caused by increased tissue density. So things that would cause that would be fluid accumulation. Or we're listening for sounds that are hyperresonant. So that means decreased tissue density. So things like a pneumothorax. So in Mike's case, normal resonance that we're hearing when we're performing the percussion test.
Okay, so all I'll get you to do is just take some deep breaths in and out through your mouth for me. All right. Good. All right, just a mild expiratory wheeze I've heard there on the front. I'm going to do this again on the back for you, all right?
Mm-hmm.
Okay.
So final part of the assessment, chest auscultation. We're listening to the lungs and we are trying to hear different sounds during the inspiratory and expiratory phases, which can help us make a provisional diagnosis. In Mike's particular case, what we're hearing is full field expiratory wheeze. That means there's difficulty getting air out, which indicates some sort of obstructive disorder. So we typically hear that wheeze sound during cases of asthma or COPD. All right, so provisional diagnosis time. Well, we've got Mike, he's 68, he's complaining of shortness of breath. He said he's had it for a couple of days. And today when we've arrived, his rest rate's 28 and his temperature is 37.8. So there's two highlighting things right there. And we've conducted our respiratory assessment. All we've been able to find is that he's mildly tripoding and we can hear full field expiratory wheezes. The only other sort of highlight that we've got is that we've got some risk factors and that he's a chronic smoker and that he doesn't see his GP very often. With all this information together, I've come to a provisional diagnosis that we've got some sort of exacerbation of COPD from some sort of infection. So febrile from the infection where he's got it, an undiagnosed emphysema, which has probably caused this respiratory distress that he's called the ambulance for. So management of him, every service is going to be different, but pretty much consistently, we're looking at some sort of bronchodilators, being it salbutamol, Atrovent type ones, and we're also looking at some sort of corticosteroids, so dexamethasone, hydrocortisone, something like that, just to try and help alleviate longer than the short-acting bronchodilator. Thank you for watching. Please provide some feedback. Be very keen to learn more in regards to respiratory assessment and making these videos.